To the deep dive. Today, we're going to try and unpack the often pretty confusing world of medical business and coding.
It definitely can be.
Yeah, and one of you actually shared a really great resource with us. It's called Fundamentals of Medical Business and Coding by Pradeep Kumar. It's a 2025 publication, apparently.
Oh, very current then.
Right. And it even has a contact number, 700-798-9291, listed in the source details. Anyway, our goal here is to pull out the really important stuff from this book.
Kind of a shortcut through the complexity.
Exactly. A shortcut to understanding how the money side of healthcare works. We'll focus on medical coding, who the different players are providers, payers, how payments actually get calculated, and the really crucial bits about privacy and compliance.
So you listening can hopefully feel a bit more clued in and maybe less overwhelmed by it all.
That's the plan. So where should we start this deep dive?
Let's begin right at the beginning. What actually is medical coding? The book explains that basically every time you interact with healthcare, a checkup, tests, surgery, whatever, it creates a medical record.
Right, like a log of everything, what the doctor saw, test results, what they did, how things turned out. It's the whole story.
Exactly. A detailed story and medical coding.
Yeah.
That's taking all that written story and translating it.
Translating it into what?
Into standardized alphanumeric codes.
Yeah.
It's like creating a universal shorthand.
A shorthand so everyone, doctors, hospitals, insurers, uses the same terms for the same things.
Precisely. Instead of long descriptions, you get a specific code for a diagnosis or a procedure.
Okay, so what are the main code sets, the main types of this shorthand?
There's a few key ones you need to know. For diagnosis, what's wrong with the patient, we mostly use ICD-10-CM.
ICD-10-CM. Got it.
Then for procedures, what was done, you've got CPT, that's current procedural terminology, and also ICD-10-PCS, which is mainly for inpatient hospital procedures.
CPT and ICD-10-PCS for procedures.
And lastly, there's HCPCS Level 2. That's for things like medical supplies, ambulance services, drugs administered in the office, that sort of thing.
ICD for the what? CPT, PCS for the what was done, HPPCS for the stuff. Why go to all this trouble, though? What's the point of turning records into codes?
Oh, the value is huge. First, data collection. These codes let us track health trends, see how well treatments work on a big scale. Second, cost evaluation, understanding the resources used. Third, and this is a big one, reimbursement. It's how doctors and hospitals actually get paid.
Right, the billing aspect.
Well, yeah, but it's also used for analyzing quality of care. So it's much more than just billing.
It really underpins a lot of how the system functions then. Now, who actually does the coding? Is it the doctors?
Well, the book says physicians are kind of the first coders because their notes are the source material.
Their documentation is key.
Absolutely. But then you have professional medical coders. They're the experts who translate those notes, so sometimes they act as auditors too. Their job is making sure the codes are accurate and complete.
And they might have to go back to the doctor.
Often, yeah. To clarify things, if the notes aren't clear or detailed enough, the book really stresses this. Incomplete documentation leads directly to incorrect coding.
That seems like a critical point. Bad notes, bad codes, bad data, maybe even wrong payments.
You got it. It messes up the whole chain.
Why? The book then gets into different coding specialties, so it's not just one type of coding.
No, definitely not. Just like medicine has specialties, coding does too. A big split is outpatient versus inpatient.
Outpatient first. What's that cover?
Outpatient coding is for services where the patient isn't admitted to the hospital. Think doctor's office visits, clinics, hospital outpatient departments. You're in and out, basically.
And the codes used.
Mostly CPT, HCPCS Level 2 for supplies or drugs, and ICD-10-CM for the diagnoses.
Okay.
And for outpatient payments, especially with Medicare, you hear about APC's ambulatory payment classifications. They bundle services into groups with a set payment rate.
APCs for outpatient payment bundles. Got it. What about inpatient then, when you are admitted?
That's inpatient coding. Focuses on hospital services for admitted patients. The main code sets here are ICD-10-CM for diagnoses, but for procedures, it's ICD-10-PCS.
So PCS replaces CPT for inpatient procedures.
Largely, yes, for the hospital billing part. And on the inpatient side, the payment system often revolves around MSDRGs.
MSDRGs.
Medicare Severity Diagnosis-Related Groups. It's a system that groups patients based on their diagnosis, procedures, severity, and expected resource use. Hospitals get paid a predetermined amount for each DRG.
So APCs for outpatient, MSDRGs for inpatient, different payment mechanisms for different settings.
Exactly. They drive reimbursement in their respective areas.
The book also mentions risk adjustment coding. What's that about?
Risk adjustment is a bit different. It focuses only on diagnosis coding using ICD-10-CM.
Just diagnoses. Why?
The goal is to capture how sick a patient population is. It helps predict their future healthcare costs. Health plans, provider groups, government programs use it to make sure payments accurately reflect the health status, the risk of the people they cover.
So it ensures that providers dealing with sicker patients get compensated fairly for that higher risk.
If that's the idea, yeah. It applies across all settings, inpatient, outpatient, wherever.
Interesting. Now, this field sounds like it changes a lot. What about the coder's role itself? Is it static?
Oh, absolutely not. The book makes a big point about this. Coding is constantly evolving. Code sets get updated, sometimes even quarterly.
Quarterly, wow.
Yeah. So continuing education isn't just a good idea, it's essential. Coders have to keep up with new codes, new rules from payers, new technology impacting documentation. It's a field where you have to be a lifelong learner.
Definitely requires staying on your toes. Okay, shifting gears slightly. The book talks about the hierarchy of providers. Who are we talking about here?
The basic split is between physicians, MDs, and DOs, and non-physician providers, or NPPs.
NPPs include
Physician assistants, PAs, nurse practitioners, NPs, clinical nurse specialists, those kinds of roles.
And what's the key difference from a business or coding angle?
Two main things the book notes. One, NPPs usually work under some physician oversight, though how much varies by state and their training. Two, payers often reimburse for services provided by NPPs at a lower rate than the same service by a physician.
Okay, so oversight and potentially different payment rates. That makes sense. Now, let's tackle the payers. This is where it can get really confusing for people.
It really can. But you can generally break it down into two big categories: commercial insurance and government insurance.
Commercial is like Blue Cross, Aetna, the private companies.
Exactly. They offer plans covering hospital stays, doctor visits, major medical expenses, all that.
And then the government side. That's Medicare and Medicaid primarily.
Correct. Medicare is the federal program, mainly for people 65 and older, and some younger people with disabilities. It's run by CMS Centers for Medicare and Medicaid Services.
And it has different parts, right? A, B, C, D.
Yes. Part A is often called hospital insurance, covers inpatient stays, skilled nursing facilities, hospice, some home health. Part B is medical insurance, covers doctor visits, outpatient care, preventive services, medical equipment.
Got it.
Part C is Medicare Advantage. These are private plans approved by Medicare that bundle parts A, B, and usually D, prescription drugs.
So C is like an alternative way to get A and B, maybe with extras.
Kind of, yeah. And Part D is specifically for prescription drug coverage.
Okay, that clarifies Medicare's parts. What about Medicaid?
Medicaid is different. It's a joint federal and state program. It covers low-income individuals and families, pregnant women, children, elderly adults, people with disabilities.
Joint program means states have a say.
Yes, eligibility rules and the specific services covered can vary quite a bit from state to state because states co-fund and administer it under federal guidelines. The book also mentions specific children's programs, like CHIP, which also vary.
Wow, yeah, definitely a complex landscape of payers. Now, how do these payers, especially Medicare, figure out how much to actually pay doctors? The book talks about RBRVS.
Yes, RBRVS, Resource-Based Relative Value Scale. That's the system Medicare uses to determine physician payments.
Resource-based, so it's based on the resources used.
Exactly. It tries to assign a relative value to each service based on the resources needed to provide it. It's not just a random fee.
What kind of resources are we talking about?
There are three main components. The biggest, about 52%, is physician work.
Okay, what does that entail?
It considers the time, the technical skill, the physical effort, the mental effort and judgment needed, and even the stress involved for the physician performing the service.
So the actual doctor's effort. What's next?
Second is practice expense, or PE. That's around 44%. This covers the overhead costs, rent, staff salaries, supplies, equipment. And this value can change depending on where the service is done.
How so?
There's usually a higher PE value if it's done in a non-facility setting, like the doctor's own office, versus a facility setting, like a hospital outpatient department, because the doctor bears more overhead cost in their own office.
Ah, okay. That makes sense. And the third component?
That's malpractice insurance, or PLI, professional liability insurance. It's the smallest piece, about 4%, covering the cost of liability insurance premiums.
Work, practice expense, malpractice insurance. Those three add up.
They add to a total relative value unit, or RVU, for each specific CPT code. The book gives an example for code 99214, a common office visit.
Yeah, let's hear it.
Okay, for 99214, the work RVU is 1.92. The PE RVU is 1.73 if it's non-facility
Mm.
office, but only 0.82 if it's facility hospital. The malpractice RVU is 0.14.
So the total RVUs are different depending on the location.
Right. Add them up. Non-facility total is 3.79 RVUs. Facility total is 2.88 RVUs.
And how does that RVU number turn into actual dollars?
Medicare sets a monetary amount called the conversion factor each year. You multiply the total RVUs for the service by the conversion factor to get the Medicare payment amount. Many commercial payers also base their rates on RVUs, though they might use different conversion factors.
That really breaks down how those payments are built. Okay, another key concept. Medical necessity. What does that mean?
It's fundamental. Medical necessity basically means a service or supply has to be reasonable and necessary for diagnosing or treating a patient's illness or injury, meeting accepted medical standards.
Yeah. Payers won't just pay for anything.
Definitely not. They only cover things deemed medically necessary for that specific patient's condition.
And who decides what's necessary? Are there rules?
Yes. For Medicare, there are national coverage determinations,
Uh-huh.
NCDs. Those apply everywhere. Then there are local coverage determinations, LCDs.
Local.
Yeah, these are set by the regional Medicare administrative contractors, the MACs, that process claims. So a rule might apply in California, but not Florida, for example. They provide more specific guidance for their region.
And private insurers.
They have their own medical necessity guidelines, usually spelled out in their provider contracts. So you always have to check the specific payer's rules.
Got it. Now, what if a provider thinks Medicare might not cover something? That's where the ABN comes in.
Exactly. The Advanced Beneficiary Notice of Non-Coverage, or ABN. It's a written notice you give to a Medicare patient before providing a service that you suspect Medicare might not pay for.
Why give them notice?
It informs the patient that they might have to pay out of pocket. It lets them make an informed choice. Do they still want the service, knowing they might be responsible for the bill? It protects the patient from surprise bills and allows the provider to potentially bill the patient if Medicare denies.
So it needs to be clear what has to be on it.
It has to list the specific service, explain why Medicare might deny payment, and give a good faith cost estimate.
A cost estimate. How accurate?
The book mentions the estimate should be within $100 or 25% of the actual cost, whichever is greater. The official form is CMS R131, downloadable from cms.gov.
Important detail. And does this ABN work for all insurance?
No, that's a key point. ABNs are specifically a Medicare thing. Other insurers have different rules or processes for potential non-coverage, so providers need to check those contracts.
Okay, ABN for Medicare potential denials. Moving on to a huge topic. Privacy and security. HAPA.
Yes, HAPA. The Health Insurance Portability and Accountability Act. It's the main federal law protecting the privacy and security of protected health information, or PHI.
And PHI is?
Basically, any health information that can be linked back to an individual. Name, diagnosis, treatment dates, billing info, images. It's very broad. Protecting it is crucial for patient trust.
Who has to follow IPA?
HIPAA defines covered entities. This includes health plans, insurers, Medicare, Medicaid, healthcare clearinghouses, like billing services that process data, and healthcare providers, doctors, clinics, hospitals, dentists, etc.
So pretty much everyone handling health info, what's the main rule they have to follow?
The minimum necessary standard. This principle says you should only access, use, or share the minimum amount of PHI needed to get a specific job done.
Don't grab the whole chart if you just need the date of birth for a claim kind of thing.
Exactly. Limit the exposure.
Are there exceptions? Times when minimum necessary doesn't apply?
Yes. Disclosures for treatment purposes between providers don't require minimum necessary. Disclosures to the patient themselves when they request their records. And disclosures required by law, like for public health reporting or court orders.
Makes sense. The book also mentions ATEC. What was that?
HAC, Health Information Technology for Economic and Clinical Health Act, came along in 2009 as part of the economic stimulus package.
And it changed ATEC.
It significantly beefed up HAC, especially for electronic health records. It increased penalties for violations, added breach notification requirements, meaning patients have to be told if their unsecured data is compromised.
Breach notification, right. That seems important.
Very. It also gave patients new rights, like requesting an audit trail to see who accessed their electronic records. It really pushed IT into the digital age. The HHS website actually has examples of enforcement actions if you want to see real-world cases.
Good to know. Okay, nearly there. The book briefly touches on fraud and abuse. Why is this such a focus?
Because healthcare fraud and abuse costs taxpayers billions and can harm patients. We're talking about things like billing for services never performed, billing for unnecessary services, or illegal kickbacks for referrals.
Who polices this?
The main federal agency is the Office of Inspector General, OIG, within HHS. They have the authority to investigate and enforce laws against fraud in Medicare and Medicaid. The book mentions the OIG work plan.
What's that?
It's published annually and outlines the areas the OIG plans to focus its audits and reviews on for the coming year. It gives providers a heads up on potential areas of scrutiny.
So providers should pay attention to that work plan. The book also gives a nod to the AAPC. What is that?
The APCC used to stand for the American Academy of Professional Coders. It's a major professional organization for people in the medical coding, billing, auditing, and compliance fields.
So a resource for professionals.
Yes, they offer training, certifications like the CPC, Certified Professional Coder Networking, continuing education. Very important for people in this line of work.
And finally, the book wraps up by stressing the need for compliance rules and audits within healthcare organizations.
Absolutely essential. With all these complex rules, coding guidelines, payer policies, IPA, fraud laws, organizations need strong internal compliance programs and regular audits.
You catch errors, prevent problems.
Both. To ensure accuracy, operate legally and ethically, and ultimately protect themselves and their patients. It ties everything together.
Okay, let's try to quickly summarize the big takeaways. We started with medical coding, that translation process using ICD, CPT, HCPCS.
Right, and the different specialties like outpatient, inpatient, and risk adjustment coding, all requiring ongoing learning.
We talked about providers, physicians, and NPPs and the different types of payers, commercial versus government like Medicare and Medicaid with all their parts.
Then we dug into how physicians get paid via the RBRVS system work, practice expense, malpractice RVUs.
And the crucial concept of medical necessity, backed by NCDs and LCDs, plus the ABN for Medicare potential denials.
Can't forget HIPAA for privacy and security, the minimum necessary rule, and how iTech strengthened it for electronic data.
Plus the constant fight against fraud and abuse led by the OIG. And resources like AAPC and the need for compliance program.
It covers a lot of ground.
It really does. Hopefully for you listening, this deep dive hits some of those aha moments the book aims for, making the business side of healthcare feel a little less like a black box.
Understanding these pieces definitely helps you navigate the system, whether you work in it or just use it as a patient.
Absolutely. So here's something to think about. We talked about how dynamic coding is, how technology impacts things like HIPAA with iTech.
Right, things are always changing.
So looking ahead, how do you think technology, AI, maybe, or other advancements will continue to reshape medical coding and compliance? What does that mean for the people doing the work and for us as patients trying to make sense of it all?
That's a great question. How do we balance harnessing new tech with keeping those core principles of accuracy, privacy, and ethics front and center? Definitely something to consider.